Hello, RDs and RDs to be. Welcome to the RD Exam Ready podcast. I'm Zak Kaesberg, your tutor, your coach, your guide along the path to passing the RD exam. My biggest passion is to help RDs and RDs to be just like you to know how to effectively pass the CDR exam. And if that sounds like you, then hey, you're in the right place. I hope all of you that have joined me for some recent RD Exam Ready lives will continue to join me for an upcoming live this Wednesday. July 15th of 2026 at 7 o'clock Central Time, 8 o'clock Eastern. We're going to be going through another session of practice questions. So please go to the YouTube, subscribe if you haven't to RD Exam Ready Live. Go check that out and join us for that session that we're going to do some practice questions. Nutrition, whether it's in the community program or an individualized patient, it always starts at a certain point in a story. It always starts with what? Well, think back, RD to be. Think back a little bit to the nutrition care process to help clue you in about what does it all start with. It always starts with a nutrition assessment every time. I'm a huge fan of the nutrition care process. I'm a huge fan of any type of standardized plan or guide to help me provide the best level of patient care. And I love nutrition assessment as well because it really does allow you to get the full story on your patient, on an individual or a group to know what their needs are actually going to be. If you can think about this beyond, our job and what it is, we think about AI and AI integration. There's one thing that AI can't do as well. It's kind of pull this whole picture together of the subjective and the objective when it comes to working and assessing a patient and kind of giving that human response. Today, we're going to spend time talking through nutrition assessment, making sure that you know how to start this story of working with a patient. Why I think it's important for the exam is because there are many questions that are centered around assessment or the assessment data that we find and use beyond nutrition assessment. Assessment, as we said, this is the first step of nutrition care process. Let's make sure we've defined effectively what assessment is and its purpose. Assessment is purely an evaluation of a patient or group, and we would use the information such as their medical, social, nutritional, anthropometric, lab data, subjective data, and we take all this data together and compile it together to come up with an evaluation or just see where this patient is nutritionally. So it's an evaluation of all that information, and it has the purpose of identifying nutrition related problems and their causes and their significance. It's also mentioned too that assessment is not a one time thing. You don't just assess someone once typically. You're constantly seeing patients, assessing patients, reassessing patients to see how they change in their nutritional status, labs, use of medications, anthropometric data. Long story short, it's a continual process. The data and the indicators that you take from the nutrition assessment are what's going to guide you along to your nutrition problem, your diagnosis, intervention, monitoring, and evaluation from here. Assessment begins with nutrition screening of some kind. Commonly in practice, there is many screening tools that exist and they're out there. These screening tools are used for assessment, usually when a patient is going to be properly right admitted. It's really going to help to try to get a whole picture of the patient, and you can use a good intent of time on it. That being said, we're not going to be doing all of our nutrition screening tools today because it could get its own episode. It could take us forever and endless time. But I do want you to be familiar with some screening tools. Screening tools you may be familiar with is like the MST, right? The malnutrition screening tool that assesses weight loss, level of weight loss, and recent decreased appetite or intake to an acute hospitalized patient. It's great for that. There's other tools like the mini nutrition assessment or the MNA, which is really well utilized for patients over 65 years or older and can assess things such as their intake, functional status. We've even got tools such as the SGA, the Subjective Global Assessment, which would look at things like medical, historical, physical examination, food intake, weight change, GI issues, presence of edema. You get the picture. I'm going to want you to be familiar with those different nutrition screening tools in the text, knowing some of the pros and cons of each of them. We'll probably do an episode in the future just on screening tools themselves, so take a look out for that if you're looking for it. The Academy asks us dietitians to also operate with knowledge of evidence based risk factors. Now, for the exam, there's not going to be a million risk factors that you need to know or study. That's not the case. But what I think we need to understand what they're saying here is that when you're assessing a patient, there's going to be data that you acquire and you use through practice that'll make you associate or correlate with a disease state. An example of this is when you're working with a morbidly obese patient, and that morbid obesity being a risk factor for cardiovascular disease. That's something that's good to know, right? That's important because it really becomes essential for identifying a proper nutrition problem as it relates to their disease state. Let's use some more examples. Let's use the same example of body composition and how it relates to CKD long term outcomes. Maybe we can review the evidence guidelines that are out there that says underweight leads to poorer results for CKD and overweight leads to poorer results for CKD. These are the types of risk factors that you just kind of need to understand through practice. And you're going to pick a lot of this up as you go through your MNT. You're going to pick up the knowledge of the etiology, some of the labs, some of the things that you see that follow along with a disease state. And that's going to help kind of develop a bit of a list or a repertoire of different MNT risk factors that we see here. But for now, generally understand by saying that evidence based risk factors are risk factors that are tied to diseases. These can be used to properly address a nutrition problem and a diagnosis based on this data. A part of assessment is also your ability to prioritize a patient according to their nutrition risk. Some of those screening tools that we use out there are going to prioritize a patient based on like a score, right? So a higher score on a screening tool would generally mean that that patient is probably at higher nutritional risk compared to someone with a lower score, right? On most of these, if you have a high score, it means you're at nutritional risk most of the time. That's what we can see. When you're prioritizing patients based on nutritional risk, I would remember this point in a few different things. There's not really a set guide on how to always prioritize a patient. You have both objective and subjective data to help you with making that decision. Let's go back to my MST, my malnutrition screening tool, and let's talk about 5 patients, okay? 3 patients, right? So we have 3 patients admitted today that we'll look at. I look at their MST scores and I want to prioritize in them. Let's say for our first one, remember for MST, the first question is, have you recently lost weight? Yes or no. No gets a 0 points and yes gets 2 points. It also asks you how much weight have you lost. So if you've lost about 2 to 13 pounds, you get a 1. 14 to 23 pounds, you get a 2. 24 to 33 pounds, you get a 3, and so on and so forth. Then it also asks you, have you been eating poorly? Yes or no. No is going to be a 0. Yes is going to be a 1, right? So if I have a patient that comes in and has an MST score of 1, okay, let's say patient A, they come in, they have a MST score of 1. They came in, they have poor appetite because they have the flu. Maybe we'll say that in that case, okay? Then let's kind of look at other patients here because if they just have the flu and they have an MST of 1, maybe I'm not as worried about them or I'm not going to prioritize them as high. Let's use patient B. Patient B will have an MST score of 4, where yes, they've lost weight. Yes, approximately 14 to 23 pounds, but no, their appetite's been okay. Should it be clear here that this patient is at higher nutritional risk than the first person that we talked about, right? They're definitely going to be. Let's take patient C. Patient C has an MST score of 6. So yes, they've lost weight without trying. Yes, they've lost 14 to 23 pounds. And yes, they've been eating poorly because of decreased appetite. Do you see how objectively we were able to rank and prioritize these patients based on the MST score? That was kind of easy, right? To make that objective decision to say that. Now, there's going to be moments too where you may have to subjectively prioritize a patient. And this is the part where I don't think we really have a guide for. It's kind of using practice and evidence and what we've seen in our jobs a little bit. So let's talk about this a little more. Let's say I'm doing ICU coverage, okay? So I'm covering ICU on the weekends, and I have one patient, patient A, who's been elevated from the surgical floor. They're still breathing, they're able to feed themselves, they're able to talk, they're doing okay. Let's say patient B. Patient B was in a car accident last night. He is completely on a ventilator. He has an oral gastric tube. He's not able to breathe on his own or eat any food. Okay, well, between those two patients, if I have patient A, the surgical patient, or patient B, the vent patient, well, I'm going to prioritize that one which who has higher nutritional risk, which guess what? That's patient B. That's the guy that's on the vent, okay? The guy in the vent is going to have much higher nutritional risk compared to our person on the surgical floor. At least that's what I believe, because if he's on a vent, he's not going to be able to feed himself. He's going through ebb and flow states. His metabolic rate is probably higher. He's going to be at higher risk for malnutrition, probably compared to the surgical patient who can still feed themselves and maybe eating fine. Do you kind of see here how I use subjective information to make that decision and say, who should I prioritize when and who needs to be put at the top of the list in that case? This is going to help you to decide how much risk that they have. Again, try to play with these in questions and use critical thinking. Critical thinking is going to be very key when you're trying to prioritize those patients. Use that critical thinking, fall back on what objective data you have to help you prioritize who's most important. Now, the exam also wants you to know about the 9 domains of nutrition assessment data. I know, a lot of info to go with, it's very overwhelming, but what I want to reassure you of is that several of these domains are things you already know. They're very easy for you to understand because you know the basics of assessment. Let's go through these together. Data from your assessment could be starting with our food and nutrition related history. This is our first one, is food and nutrition related history, and that's going to be the data that you're going to acquire from speaking with that patient or their family, caregivers, etc. Should there be food and nutrition intake, how they get their food orally through a feeding tube, medications, alternative medicines, supplements, beliefs, attitudes, behaviors, access to food. This is all information that's going to fall within that food and nutrition related history. So, mostly just asking about how their appetite's been, their intake, what has their eating been like, whether it's orally or through a tube. The next one that we have for number 2 here is going to be anthropometric measures. If English is your second language, you might not be familiar with this term, but you might know what it is when you see it. Anthropometric measures is going to be measurements of things like their height, their weight, their desired body weight, their usual body weight, their BMI, small frame, large frame, loss of a limb, for instance, or muscle and body fat composition. This would all pull into your anthropometrics data. And I would throw in here too, yeah, like usual body weight, recent weight loss. This is all going to fit in anthropometrics for me. The third domain is going to be your biochemical data, medical tests, and procedures, basically labs and surgeries. So, we're of course going to be looking at those patient labs to make sure their electrolytes, their blood sugars upon admission, see how those things are looking. And we're going to look at tests or surgeries they might have had in the past, such as if they've had a past history of bariatric surgery where they have a gastrectomy. Well, that's definitely going to alter your nutrition assessment information. That's the type of data you need to be pulling into assessment because it's super essential for really fully assessing that patient, right? Your fourth domain is going to be your physical exam findings. So, the findings that you get from your nutrition focused physical exam will help dictate that. Make sure you're nice and familiar on nutrition focused physical exam and how that all fits together. The fifth option is domain is going to be client history. It's going to be the personal health, family, and social history of the patient. This could be things like age, gender, ethnicity, as well as their social history and dynamics. Throughout your assessment, you're also going to be focusing on number 6 here, looking at assessment monitoring and evaluation tools used. Tools that help track health or disease status, risk assessment, reassessment, your MST scores, your subjective global assessment scores, those could all fit into these tools here. Seventh category is your etiology. Etiology, remember, is your cause. What this is saying is, so this is the cause or the category cause, that's categorizing the type of nutrition diagnosis etiology or things that are really going to factor into that primary nutrition problem. What this is factored into me is like if you're finding a primary nutrition problem of obesity, let's say it's leading you down that road, well, in this etiology category, that's where you're entering things like excessive intake or lack of physical activity, maybe causes that you know are going to contribute to the nutrition problem that you're choosing. We're almost done with this list here. Our next one is comparative standards. And this is a major one because you know that once you go through the assessment, you're going to calculate things like how much energy they need, how much protein they require, and then you're going to compare that to the types of amounts that they're eating in their diet. This is going to help to do things like sell your intake diagnosis, right? For intake diagnosis for your nutrition problem, you're going to have to give evidence to their intake not being good enough. And comparative standards are actually really perfect for that because comparative standards can look and say, hey, they need 2,500 calories per day, but they're only getting 1,700 or something like that, right? This is also where you'd find things like macronutrient, micronutrient, supplementation data, any findings that they're going to have deficiencies. This would also factor into this piece of comparative standards. So looking at what do they currently eat compared to what their body requires. Super helpful there. Last domain is a little bit hard to understand. It's called the progress evaluation, and it includes terms that are used to describe how the patient is progressing towards the nutrition related goal and resolution of the nutrition diagnosis. So, maybe if your nutrition goal is related to getting the patient more intake through enteral feedings, you could drop in this area and describe the patient's progress towards getting more enteral feedings completed. I've got a little memory trick for these because they are difficult a little bit. So here goes. Frolicking, piggies, pass, baked, chocolate, croissants to every lovely adult. Frolicking piggies, pass baked chocolate croissants to every lovely adult. 9 domains here. What that's going to stand for is F, frolicking stands for food. Piggy stands for physical, pass stands for progress, baked stands for biochemical, C chocolate stands for comparative standards, C croissant stands for client history, 2 stands for tools, etiology stands for every, and then anthropometrics, let's see, our L is going to be our anthropometrics to every lovely adult there. 1, 2, 3, 4, 5, 6, 7, 8, 9. Let's go ahead and just adjust that one more time. So it's going to be frolicking piggies pass baked chocolate croissants to every adult. That would stand for food, physical, progress notes, biochemical, comparative standards, client history, tools, etiology, and anthropometrics. Frolicking piggies pass baked chocolate croissants to every adult. Those are the domains that we need to be familiar with for the exam. And keep in mind, we haven't done every single one of the topics, or we didn't discuss today every single one of the topics in there, like vitamins and minerals or screening tools. Those are going to get their own episodes someday, or you need to study those a little bit more on your own. Take this session to really focus in on the domains themselves, really understanding those in case a question is to pop up with it. Use what lessons we've kind of completed on the assessment to dig deeper now. Go into those different lessons, check out the RD Exam Ready YouTube page, look at some videos we've done, look at other episodes I've done to really help guide you. For instance, I know we've done lives on vitamins and minerals before. That's going to be helpful to give you more of the detailed information that you need to know for the nutrition assessment piece. Now that you've sat through that, let's apply this to some practice questions today. Number 1, information such as lab tests and past surgical history would fall into which of the following assessment domains? A, food and nutrition related history. B, physical exam findings. C, etiology. Or D, biochemical data, medical tests, and procedures. Information such as the lab tests and past surgical history would fall into which of the following assessment domains? Would it be A, food and nutrition related history, B, physical exam findings, C, etiology, or D, biochemical data, medical tests, and procedures? So as I look at this, A, B, C, and D to really use process of elimination, starting with A, food and nutrition related history, this doesn't seem like a good fit to me because that seems like it's going to be more that data of how have they been eating, what have they been eating, what are their beliefs, and what's their knowledge. I'm going to rule A out based on that. For B, physical examination findings, unless it's going to show me a surgical scar of some kind, the physical exam findings would more than likely be doing a lot of things like our malnutrition screening could be done during that phase, listening for bowel sounds, stuff like that. But it's definitely not going to tell me anything about lab tests, so B is out for me too. C, etiology category. That may possibly be something related to my historical or surgical history. I'm going to put a little question mark by that. Or D, biochemical data, medical tests, and procedures. This would be my best domain for this question here. So, information such as a lab test and past surgical history would fall into which of the following assessment domains? That would be D, biochemical data, medical tests, and procedures. Number 2, a dietitian is asked to assess a series of patients in a day. Which of the following patients should the dietitian prioritize? A healthy 85-year-old who lives at home. B, a 32-year-old underweight patient with oropharyngeal cancer undergoing treatment. C, a 10-year-old with the flu whose BMI for age is in the 40th percentile. Or D, a 50-year-old man who self-administers tube feeding at home. A dietitian is asked to assess a series of patients. Which of the following patients should the dietitian prioritize? Let's start with A healthy 85-year-old who lives at home. Well, due to their advanced age, there's always the possibility that they are at nutritional risk. They live at home, so they may be cooking meals for themselves or they might not. Let's hold on to that one and let's see about our other answers. B, a 32-year-old underweight patient with oropharyngeal cancer undergoing treatment. I like this as an answer. My reason being is that they're underweight and they have oropharyngeal cancer undergoing treatment, which shows their body is at a lot higher basal metabolic rates compared to probably normal. And with them being overweight too, I just feel like these things don't add up too well for good outcomes. I would maybe think about prioritizing answer B. Let's hold on to that one and see about C and D though. A 10-year-old with the flu whose BMI for age is in the 40th percentile. Well, sorry, 10-year-old. I know that the flu is probably pretty bad for you, but with your BMI for age being in the 40th percentile, pretty close to average, I'm not too worried about the 10-year-old too much. They'll call me if there's an actual issue. I'd get rid of answer C. D, 50-year-old man who self-administers tube feeding at home. Now, this could be a good answer. This probably would be my second best answer that could be. I don't see anything else that says of like the patient having higher basal metabolic rates or them having a disease state of some kind. So I need to go and get more information about why they're doing tube feeding. But if I was to look at this question and say what my best answer is, my best answer and who you should prioritize should be that 32-year-old underweight patient with oropharyngeal cancer undergoing treatment because their intake's going to be affected. Their basal metabolic rate is way higher than what is typically. They're undergoing treatment. They may lose the ability to swallow. They may not. And they're underweight. This all adds up to bad outcomes. So that's who I would prioritize. Number 3, kind of a weird one to throw at you a little bit, but I thought it'd be fun. Which answer would be considered as obtaining and verifying appropriate data? Number 3, which answer would be considered as obtaining and verifying appropriate data? Let's see if I can trick you. A, comparing BMI for age of a 12-month-old baby to comparative standards. B, evaluating weight history for a patient who is transitioning from enteral to oral feedings. C, assessing cooking skill of a paraplegic patient living in a group home. Or D, assessing nutrition knowledge and behaviors of a 5-year-old child. Which answer would be considered as obtaining and verifying appropriate data? So which one of these makes the most sense is what we're looking at here. Let's start with A. Comparing BMI for age of a 12-month-old child to comparative standards. Does that make sense? Well, no. We don't do BMI for age for a 12-month-old child. We don't do that for babies because we don't really do BMI for babies anyway. We do more things like weight for age and other comparative standards. BMI for age for a 12-month-old, that's a bad answer. We're going to get rid of answer A to start out. B, evaluating weight history for a patient who is transitioning from enteral to oral feedings. I like this as an answer. I think this would be a good answer to hold on to because they may lose weight as they transition from enteral to oral. This all makes sense to me. Appropriate use of data, certainly. C, assessing cooking skill of a paraplegic patient living in a group home. I don't think this is very appropriate use of data. I don't expect the paraplegic patient is going to be doing much cooking for themselves, and especially not in a group home. I'm going to get rid of C. D, assessing nutrition knowledge and behaviors of a 5-year-old child. Well, behaviors might be good because we might need to know about different food hankerings and things like that. But nutrition knowledge of a 5-year-old child, they barely know how to count. So I don't think D would be a very good answer there. Which answer would be considered as obtaining and verifying appropriate data? I would say answer B. Evaluate weight history for a patient who is transitioning from enteral to oral feedings. That's a wrap for today's lesson, students. I hope you watched, listened, learned, and enjoyed today's show. I hope you'll get a chance to join us for the upcoming RD Exam Ready Live. Keep in mind that's going to be on July 15th on that Wednesday, 7 o'clock Central Time. Remember, passing this exam is a journey. We all need assistance along the way. Do me a favor. Rate, review, subscribe, comment. Let me know how we're doing with these shows. As always, remember, happy studying to you, RD to be.